time where the legs be time is 330 or 360, he won't be able to do that. The third is an executive function in which a patient is asked to carry out a task which involves several steps. For example, you can ask a person to pick up a paper, fold it 2 times and put it in his pocket. If he is able to do that, it means his executive function is right. And then is a language dysfunction where patient knows a lot of things, but he cannot recollect the exact word for that thing at that point of time. He may recollect it after a certain point of time. So these are the 4 things you have to keep in mind, and not memory alone. One is memory, one is visuospatial function, one is executive function, and one is language dysfunction.
Thank you, sir. Now I have questions to Dr. Rashmi ma'am. Why is age-related memory loss mistaken for dementia?
So these two conditions in their early stages are having overlap symptoms and signs. That's why there could be misdiagnosis. And other factors could be if the clinician is too busy, then many times they are not able to give proper time for detailed clinical history and assessment of the cognitive scores. So that can also lead to mistaken diagnosis. Apart from that, many times patients and their families also, either they are under-reporting the symptoms or they are over-reporting the symptoms. Maybe they are ignoring the serious symptoms, just attributing these symptoms to the normal aging pattern, and then diagnosis can be missed. So these are the few things which can lead to the diagnosis confusion.
One more important thing is that family history we have to take care of it. If the patient's family is having something, some person is having a history of dementia or Alzheimer's, then the more chances of getting the patient towards dementia are there. So we have to give, ma'am very well said, we have to give the patient full time and we have to listen. It is not abnormal to have 1 or 2 times missing the keys, but regularly missing the keys and regularly forgetting the things come under the dementia. Thank you, ma'am. My question is to Dr. Can you have memory loss but no dementia?
Yes, you can have memory loss but not dementia. Memory loss is in continuum. As we age, we get wrinkles around the eyes, we get gray hair, we get a lot of things. Similarly, every one of us, when he crosses the age of 30 years, will have some amount of memory loss. But all memory loss is not dementia. There is a continuum. The first thing is age-associated memory impairment. In some it worsens to mild cognitive impairment, and in the disease form it becomes dementia. So every one of us has age-associated memory impairment. After a certain point of time, anyone of you who is over the age of 45, so none of you look like it, but I'm sure when you are writing a medicine which you have written for at least 100 times, sometimes you have to think what was the name of medicine even if you had written it yesterday. This happens, but this is not dementia. This is age-associated memory impairment. There is a slight difficulty in recalling the medicine, and as soon as you get some clue, or after some time when you are thinking about something else, that thing will come to you. So this is age-associated memory impairment. This is nothing to worry about, just like your gray hair. The next thing is mild cognitive impairment. Here also, memory is impaired, but the other functions which I told you, the visuospatial, the executive, and the language functions, they are intact. And dementia is obviously, it is a progressive decline. All 4 domains of the higher mental functions are affected, and it is so much that it interferes with activities of daily living. So if you have sometimes mild impairment in recalling something and which can be aided by clues, then it is age-associated memory impairment. There is nothing to worry about because every one of your age group will have the same thing. And it is not a very subjective thing. You actually have scales. Like you have a stroke scale, so you have a memory scale, which is there for every age group. So if you compare, if you will come to me and if you will tell me your real age, which is difficult, but if you tell me your real age and if you are of the age around 45, we will have a different scale. If you are from 55 to 60, we will have a different scale. And none of you will tell the age above 60, but still we have scales for that. So this is how it goes. In age-associated memory impairment, there is only memory loss, but it is normal for age and it will be decreased as compared to the young. Other domains are not affected and activities of daily living are not affected. You can still fight with your husband like you always used to do. You don't forget his name, nothing like that. In mild cognitive impairment, there is again memory loss, but is impaired for age. So 45-year-old Dr. A and a 45-year-old Dr. B, one might be having age-associated memory impairment. The other person would have a memory which is much less than Dr. A, and it would be mild cognitive impairment because her memory is not falling within that curve which should fall for her age. So these are the two. Dementia, apart from memory, multiple domains are affected, and they are sufficient to impair your activities of daily living. So this is a brilliant definition. Everything you want to know about dementia is in this definition. And let's go word by word. It is an acquired decline. So a person who's born mentally retarded is mentally retarded, but he is not demented. Because it is not acquired, it is congenital. Second thing, it is a progressive or persistent decline. For example, someday my wife hits on my head with a balloon and I start forgetting something. So it is not dementia, it is head injury, maybe extradural hemorrhage. Because this decline is not going to be progressive.
11 बजे तक 11 साढ़े 11
It should affect multiple domains. Apart from memory, it should affect your language, it should affect your executive function, and it should affect your language function, and it should be so severe that it interferes with my activity of daily living. We have a score for this, we have a scale for this. It is a test which is given in a printed paper. Anybody can download it. It takes hardly 5 minutes to do it. There are 10 questions and you are marked according to those questions, and you can know whether a patient has dementia or he has age-associated memory impairment or mild problem. Thank you.
घर पे खाऊंगा खाना
Thank you, Dr. MP. Excellent. So, sir, Dr. Vishal sir, we must ask you that what is the difference between normal aging and dementia?
Okay, bye.
Already covered, but still we want to listen a psychiatrist's point of view.
Bye.
साइकियाट्रिस्ट होने की जरूरत थोड़ी ना हर चीज हटके हो well already हो ठीक है basically we have a fixed lifespan and every cell including the brain cells have a own definitive life and they are programmed pre-programmed so a normal decline which is happening with the age and which is not global as Dr. MP said it's having a significant it's not impacting the other modalities like visual language comprehension executive function so it's a normal part of the age but if it is a global one and it is progressing then it obviously gets to the level of dementia. But basically, we have tools, whatever tools we have, they don't take into account the basically the work culture, not exactly the occupation of the person. Because dementia for a software engineer or mild forgetfulness for a software engineer will be more problematic and troublesome and will require a treatment rather than mild forgetfulness or reshuffle. So scales give you a idea to whether he is falling into that category or not, and they obviously are validated and all those things. But treating those things will depend on a lot of scenarios. What is the work profile of the patient, whether we really need to intervene. A minimal cognitive impairment for a daily laborer might not, and we can leave okay, we'll talk about this again after 1 year. But if some IT professional is working on it, a coder is working on it, and if he is having some restoring positive for entitled for for 3 months or early, so that we can get it early change in the progression. And
यार
if
यूट्यूब
he is
कैसे
marking
मैं
what
समझ नहीं आता मेरे को
he
कैसे लाइव करते हैं कैसे क्या करते हैं मेरे को कोई बताएगा
How we remember the things? This is for Dr. Gayatri.
So remembering things is we get sensory, we have all the
Subscribe
systems,
to my
the information is
channel.
put into the brain,
Yeah.
then it is encoded and it is formatted and it's stored in the various regions. So the memory is basically in the hippocampus, the hypothalamus, and then it is distributed very. The emotional memories is stored in
ये देख
amygdala.
कौन पेन
Then after that, whenever you use to remember anything, there is a retrieval
information which is done by the Prajapati. So all these informations are collected, they are linked, and then we need to read something after the storage. So in this way it happens. So recurrent episodes of doing things will hasten the memory. If it is emotionally attached, then you have stronger memories.
Very rightly said. This also is covered, I think, what is my cognitive impairment already covered, but still you can give something, some input for the.
Already experts have explained in detail, so nothing additional.
So again, to the diagram map, what are the various factors causing memory loss?
Memory loss, a major thing at present is sleep deprivation. So sleep deprivation, memory will be lost. We are unable to concentrate on. Overwork, stress, common causes like B12 deficiency. Even thyroid disorders like hypo and hypothyroidism both can do that. Apart from that, infections, encephalitis, head injuries, any concussion or repeated trauma, and other things in which waste products are deposited, like Alzheimer's disease and Parkinsonism, multiple sclerosis. So all these together, and certain medicines, like even drug abuse, alcohol, substance abuse, patients, people are more prone to have memory loss. And if the patients having chronic multi-organ dysfunction, like kidney, liver, all these things, still there can be memory loss. And certain medicine.
What is the difference between dementia, depression and delirium?
ओके,
How can we track?
डिमेंशिया के बारे में तो मेरे ख्याल से आराम से बात हो सकती है कि नहीं? तो अब डिप्रेशन के बारे में बात करें। बेसिकली डिप्रेशन ऑलमोस्ट अ वेरी कॉमन साइकियाट्रिक डिसऑर्डर एंड इज प्रीडोमिनेंटली एसोसिएटेड विद मूड। ठीक है, तो अगर मोटी भाषा में कहने की कोशिश करें तो यदि 2 हफ्ते से ज़्यादा ऐसा चाहे कारण हो चाहे ना हो, अगर आपके पास कारण है तो भी कोई फर्क नहीं पड़ता और कारण नहीं है तो भी कोई बात नहीं। अगर 2 हफ्ते से ज़्यादा आपका जो मन है वो उदास चल रहा है और यदि आप में अपने जीवन के प्रति या अपने जो कार्य आप रोजाना जीवन में करते हैं जिसमें आपको करने में आनंद आता है, आप प्रैक्टिस कर रहे हैं, खेलने जाते हैं, जॉगिंग कर रहे हैं, कुछ भी हो सकता है जिसमें आपको आनंद लगता है, अच्छा लगता है, इनफैक्ट सिंपल कुकिंग और वॉट एवर द चोर्स यू आर, एंड इट इज परसिस्टेंट और वो आपके सोशल ऑक्यूपेशनल पर्सनल लाइफ को इम्पैक्ट कर रहा है, देन इट एंटाइटल्स टू बी अ डिप्रेशन। उसके अलावा बहुत सारी चीज़ें हो सकती हैं, भूख, नींद, प्यास, सेक्स, लिथार्जी, ब्ला ब्ला ब्ला, वो सब। लेकिन मोटे तौर पर सिर्फ मन एक प्रोमिनेंट फिगर ये होनी चाहिए कि आपका मन उदास है एंड यू आर नॉट फीलिंग द ज़ील ऑफ लाइफ एंड यू आर नॉट इंटरेस्टेड इन द एक्टिविटीज विच यू वर प्रीवियसली इंटरेस्टेड and this continues for more than 2 weeks. That's why in Hindu mythology or Hindu culture there is a this mourning period of 14 days. 13 होती है, 13 के बाद everything you find. Basically this is the time period which we assume